Assalamu alaikum jami'an. Thank you for the introduction, and thanks to the organizing committee for the invitation. It's gonna be, I like the fact that you put the neurologist at the end of the talk. I don't know what does that mean, but I hope that means you guys are gonna be more interested in hearing the talk. I'm sorry if my talk is the talk that's between you and the lunch, but I'll try to be fast and quick and hopefully useful. So I specialize in neurology and immunology, so we tend to get referrals for different CNS inflammatory disorders, including vasculitis. So I have no disclosures for this talk. We're going to be talking about the introduction about CNS vasculitis, primary CNS vasculitis. We're going to be talking about the challenges that we usually face, causes and mimics. There's probably every talk about vasculitis you hear about mimics. The criteria that's been used to diagnose CNS vasculitis, approach to the diagnosis and the treatment, and the outcome of those cases. So as you know, as the name says, it's primary CNS vasculitis. Some people call it primary meningitis of the CNS. It's a disease that affects primarily the blood vessels of the brain, spinal cord, and meninges, with little or no systemic inflammation or systemic cause or no identifiable cause. So whenever we find the cause, it's not primary CNS vasculitis anymore. The condition is rare, and this is why it's challenging, and it's poorly characterized. And this is why it's challenging to diagnose and also to treat. Without biopsy, we always have to be careful. And then we have to talk about demographics. This is a condition that typically affects people from the age of 20, 30, up to 60. When they did studies, most of the patients were around the age of 40. And typically in the literature, they would tell you this is a condition that affects males more than females, although there's not that much of a difference. As the title of the talk says, there is a lot of challenges in this condition because of its rarity, meaning that there is going to be not a lot of evidence in terms of diagnosis, hardcore evidence for that guides treatment. The estimated incidence based on studies in 2007 is about 2 to 4 in 1 million. And it's a serious condition. So sometimes, yes, we cannot diagnose a lot of condition, but they can be not serious, there's no treatment, so we're kind of comfortable. However, this condition is serious, can lead to disability and even mortality. The other challenge is the heterogeneity of the presentation. So different patients come with different presentations, which makes it difficult to identify and diagnose. And of course, the mimics, which going to be already Dr. Safi spoke about early on, and we're going to comment on a few of them. And sometimes those mimics also can be serious, such as neoplasms or serious infections. And the problem, even when we do our best, we suspect the disease, the tests that confirm the diagnosis are not that sensitive and not that specific. And the brain biopsy, which has been termed as the gold standard to the diagnosis, is invasive. And even when you go on and do it, sometimes you're going to come back with a non-conclusive biopsy. And of course, you are familiar with the treatments and the potential side effects and the fact that there is no good biomarker for diagnosis and follow-up or prognosis. So before we go to primary meningitis of the CNS, we have to talk about secondary vasculitis. This is a slide for why we call rheumatologists. When you saw those patients, it's basically to help us finding those diseases. And sometimes the vasculitis is not a primary disease in that condition. It can be secondary, and you guys are familiar with those conditions. And a very rare but important differential is malignancy. Sometimes lymphomas can present only with vasculopathies, which is rare but serious. And of course, drug and toxic, like illicit drugs, drug of abuse, and infections, which Dr. Savi have already mentioned a few of them, which are very important etiology and probably more common cause than primary meningitis of the CNS. This is the slides where neurologists should be helpful to you when you have a case. These are the different cases that can cause vasculopathies without significant inflammation, and it might look like vasculitis. So whenever you find like a neurologist call you, this could be meningitis of the CNS, you have to ask them, is it not atherosclerosis, is it fibromuscular dysplasia, CADASIL, moya disease? These diseases are not that rare. Yes, they're not that common, but also they're not that rare. And the first condition here is the reversible cerebral vasoconstriction. It's a very important mimic, especially when you diagnose vasculitis based on angio only. Dr. Safi already spoke about fibromuscular dysplasia. This is a slide of, this is a picture of a string of bead signs. It's actually a renal artery, but I kind of flipped it to make it look like a carotid. And then on the left side, this is a moya-moya disease, which is very common. Sorry, it's not very common. It's not uncommon, I would say. It can be primary. It can happen in any patient who have stenosis of the entire carotid artery. You would see, I don't know if I have a pointer. Yeah. So, yeah, it's going to be what we call a puff of smoke, this blur of blood vessels. This is a typical moya-moya disease, which can look like vasculitis and can present like vasculitis. So the diagnostic criteria that have been used to diagnose primary injustice of the CNS have not changed since 1980s. It requires the presence of unexplained neurological deficits, so we really have to do a good workup to exclude other etiologies, and then you need a brain biopsy or angiogram. Of course, without finding any other cause such as infections, inflammation, etc. So basically, you can diagnose primary injustice of the CNS without brain biopsy. And this is probably one of the sources of the confusion in the literature. So the presentation can be variable. They can be strokes, chronic meningitis. Someone presents with a headache, and then you do an MRI, and you find leptomeningeal enhancement. Sometimes for lucky patient, they might present with tumefactive lesions. I say lucky because that's usually an indication for biopsy, and easy to get a biopsy, and then you get a diagnosis faster. Sometimes all what you have is a headache with some abnormality in imaging. However, if the headache is severe and sudden, this is a red flag for vasculitis. This is usually suggestive of something called RCVS. And some patients present with cognitive impairment or seizures. So you can see the presentations are wide and variable. So this is a meta-analysis that I'm going to refer to in the few slides. It's probably the largest meta-analysis in the topic. It's been published in 2021. I recommend everyone to go to it whenever he wants to know more about the disease. They tried to look at all the case series that included 2 patients or more in the last 20 plus years. And they ended up finding about 900 patients, so it tells you this condition is pretty rare. And they found that the most common presentation was focal neurological signs, hemiparesis, headache, and cognitive impairment. So when you go to see the patient, you're going to do your usual history and examination, focusing also on travel, hobbies, drugs, sexual habits, and then family history of genetic vasculopathy, which is actually, it sounds easy, but it's very commonly, unfortunately, underused, underutilized, and sometimes missed. And then you're going to do the skin examination, looking for any typical signs or rashes or vascular changes. Of course, the eye, as Dr. Asavi mentioned earlier on, that it's an extension of the brain, so we recommend that patients with suspected primary injustice of CNS to see a ophthalmologist even if they have no symptoms. It can be a clue to other underlying etiologies. So what investigation you would do? In the literature, most people have recommended doing like a thorough workup before calling this as a primary injustice of the CNS. And most of the criteria, at least used in research, they added this as kind of an exclusion criteria by having any of these workups positive. So echo and Holter have to be done, blood culture looking for infective endocarditis, whole body imaging, immunologic testing, at least ANCAs and ANAs, infections looking for HIV, hepatitis B and C, and tuberculosis, syphilis and varicella zoster, in addition to a workup to exclude malignancies. So it's almost like a diagnosis of exclusion. So I guess when you get a consult for a patient with possible primary injustice CNS, you really have to make sure the neurology team have done their diligence, have done a good workup. And then the spinal fluid. A lot of us believe that spinal fluid is one of the best diagnostic tests for this disease. However, it might not be as good as what we think. And this meta-analysis, they found that up to 70% of patients have abnormal CSF, which is meaning elevated protein, basically. However, 30% of them have normal protein. And as we know, elevated protein is not really specific for any disease in the brain, and it just tells us that there is something going on. Having cells in the CSF is usually indicative of inflammation. Having too many cells, let's say 400, 500, that's possibly what suggests infection. And then the main goal of the CSF testing is to look for infections. And this is an important consideration, looking for syphilis, like Dr. Asafi's case, varicella zoster, aspergillosis. And nowadays, there is a more and more interest in doing what they call a metagenomic next-gen sequencing, where you take the CSF and just look blindly for any DNA in that CSF. And there have been case reports of cases called primary angiitis of the CNS, where it turns out that this is actual infection that is very rare and never tested. So this might be something that we do in the future routinely. There is ongoing research trying to find the pathogenic mechanisms. They found some dysregulation in the complement pathways in people with primary angiitis of the CNS. And they found interleukin-17 elevation, which is also not specific for angiitis. It tells us there is inflammation. So these are not usually done clinically nowadays. So the CSF is good, but not that exclusive. So then you go to do neuroimaging. So neuroimaging is probably the most sensitive test you can do to diagnose CNS vasculitis. 98% of patients did have abnormalities. Usually we're talking about infarcts, hemorrhages, and sometimes enhancement in those lesions or at the leptomeninges, although this is not that common. However, this is a very important slide because it's a very common misdiagnosis, very common overdiagnosis of vasculitis, very common referral to you guys and to us is non-specific white matter lesions. Nowadays, we do a lot of MRIs. And even in healthy people, you're probably going to see these spots. And usually, the radiology report is going to say something like there are white matter changes. This could be ischemic, could be vasculitis, could be demyelinating. And this is usually where patient gets referred, and they might end up having extra workup. These are completely normal and can be seen in completely healthy people unless you see diffusion restriction, meaning this is acute ischemia, or if there is enhancement with contrast, or if there is change in the blood vessel. So be careful when you get a report with these non-specific white matter changes. So then we do the angio, which has been one of the two tests that's used to diagnose vasculitis per criteria. We look for the classic beading pattern where you see that narrowing and dilatation blood vessels is usually smooth and sometimes can cause occlusions. And it has to affect multiple cerebral arteries. And in most of the studies in the literature, they tend to exclude patients who have atherosclerosis. So in real life, it can be difficult. You might see typical changes of vasculitis, but then you see some atherosclerosis. So in real life, sometimes you'll have to include those patients as vasculitis. However, in the literature, they have to exclude those patients. So it's good to look at the lumen of the blood vessels. However, again, conventional angio, whatever you see, is not always specific for CNS vasculitis. There are a lot of mimics, like we discussed early on. This is the patient with endocarditis, bacterial endocarditis, who did have like narrowing dilatation similar to CNS angiitis. And this is a patient with reversible cerebral vasoconstriction who also did have stenosis and narrowing. And when they looked at all the cases being published in the last 20 years, it was very interesting to know that the DSA was positive in only 30% of patients with biopsy-confirmed vasculitis. So there's a huge discrepancy. And when you take the people who had positive angiogram and they do biopsies, it's only 8% that came back positive for biopsy. So that tells you there's a lot of discrepancy. So that's why I guess we need to have better diagnostic criteria, better stratification of cases. So now we come to the vessel wall. I'm sure you probably have seen patients who had abnormality in what's being called vessel wall imaging. This is kind of a new technique in MRI, requires a 3 Tesla MRI with contrast. And you can see on the left side, there is, the left side of the brain usually in the right-hand side. So you can see the enhancement around the blood vessels, the hyperintensity. This is abnormal. This indicates inflammation. So this is very nice, looks very nice. It looks easy, and it's kind of suggestive of vasculitis. However, the pattern of enhancement can be also seen with atherosclerosis. So this is also another problem. However, it tends to be more eccentric, asymmetric on the side, not concentric. So when you see concentric, diffuse, symmetrical, this is more vasculitis. Eccentric tend to be atherosclerotic. So you really have to have good radiologists, experienced radiologists to tell you this goes more in favor of vasculitis or more in favor of atherosclerosis. So this is an example of patients on the left-hand side who had stenosis in the angio, and then he had positive vessel wall imaging on the left side. They treated him cyclophosphamide. The stenosis persisted, but the contrast enhancement improved. And this is another example of COVID-19 vasculitis, and which also improved. It's also confirmed by angio, by MRI of the visual wall. So it's helpful to use this technique to differentiate inflammatory from non-inflammatory cases, and it's also helpful to guide us in the biopsy, take a biopsy site, and to do the follow-up as in the case we saw, although this has been controversial. It does have limitation, as we said. Atherosclerotic lesion do have some inflammation, so you might see enhancement. So you have to be careful. Then we go to the diagnostic test of choice, which is the brain biopsy. So you don't know what's going on. You want to confirm it. You want to go for brain biopsy. So some experts in the field, they recommend doing biopsy for everyone, and the rationale is that you're going to treat them with some toxic medication. Probably the risk of the toxicity outweigh the risk of biopsy itself. It does confirm the diagnosis, and it also helps to exclude important mimics, infections such as syphilis, neoplasms, such as lymphoma. However, there is also limitation. It's invasive, it's obviously invasive. There's a risk of hematoma at the site. Usually it's mild, it's not that severe. And there's 1% risk of disability. And the main problem is the sensitivity. So even when you do your diligence, you do the biopsy, the surgeon takes the biopsy, the yield is not that high. Studies have shown that about 38% of patients would have negative biopsy, despite they have typical classic presentation. And even some of these negative cases, when they passed away and they did the autopsy, they did find the diagnosis to be vasculitis at the end. So it tells you there is a problem with sampling. This is what we call sampling error. And probably because of undersampling the meninges, the brain, and sometimes the surgeon has to go to an area where there's no imaging abnormality. So this is usually us nowadays, most of neurosurgeons would not go to biopsy healthy tissue. They would insist to go to an area which is abnormal. So some authors suggest that the ideal biopsy should be 1 cubic centimeters with the gray and white matter, leptomeninges, and cortical vessels. This is something you can tell the neurosurgeon when he does the biopsy. I mean, 1 cubic centimeter might sound small, but I have to tell you, like the brainstem itself is like 2 centimeters at length. So it's large to take 1 centimeter, cubic centimeter from the brain. So then what do you see in pathology? Typically, the classic primary and of CNS is granulomatous inflammation. You can see the granuloma at the lower part, which is the commonest type. Sometimes you see necrotizing, aggressive inflammation in the blood vessel wall. And sometimes you see only lymphocytic infiltrate, and this has been associated with a better outcome. If you stain for amyloid, you might see amyloid staining, which has been seen in different types, like granulomatous, necrotizing. The implications of that are not clear. Okay, so you did your diligence biopsies, and there's no diagnosis. So don't worry, you're not the only one. This is Calabresi, he's a rheumatologist. He's the one who made the guidelines. Who said that it's often that you're not going to reach the diagnosis. You're not going to be comfortable. This is a different diagnosis. At that point, you will treat and then do a meticulous follow-up. So treatments, as I think we already spoke about treatments early on of secondary systemic and vasculitis. In primary angiitis, as you might imagine, there's no clinical trials. Only what we have is anecdotal evidence, observational data, and it's mostly from the secondary systemic vasculitis literature. So usually treatment is more similar. You go induction, steroid, cyclophosphamide, maintenance, steroid tapering, steroid sparing agent with or without steroids. And this is when they looked at all the patients, the 900 patients. So they noticed most of them received steroids, usually oral, 1 milligram per kg, over variable periods, up to a few years, and they would sometimes give them pulse. Most of the patients received cyclophosphamide pulses, up to 12 pulses, like 12 monthly doses in some patients. And then some people, they try to induce with Imuran, Cellcept, or rituximab, or methotrexate. Maintenance treatment is also variable, more or less similar to secondary angiitis of the CNS. And some people have used rituximab also, like systemic vasculitis, ankylosing. There are also weak evidence in primary angiitis of the CNS. And in 2 refractory cases of primary angiitis of the CNS, they've used infliximab and etanercept with good success. So what happened to those patients when they followed them? The French cohort of 112 patients, they followed them for a median of 57 months. They found that 95% of them achieved initial remission in the first year. And however, 40% of them had relapses during their follow-up period. The mortality was 8%, and they noticed that people who stayed on maintenance therapy had prolonged remission and better functional status. The American cohort of Mayo Clinic, the mortality was a bit higher, like 15%, and relapses were higher. And they tried to look at patients who passed away, and they tried to do stratified logistic regression analysis, and they tried to identify a risk factor of mortality. They noticed that older age, diagnosis by angiography only, not biopsy, having a stroke or having large vessel involvement been associated with worse outcome and mortality. And by that, I summarize my slide by saying the diagnosis cannot be made with certainty without biopsy or typical angiographic findings. So in any case you have been labeled as primary angiopathy of the CNS without biopsy, without typical angiography, you have to revise the diagnosis every time. And mimic secondary causes have to be extensively worked up and discussed with the neurologist, other non-inflammatory etiologies like genetic etiologies, stroke mimics, etc. And even if you're not sure, you have to revise the diagnosis every time. And then I think this is a problem with our busy practices. We see the patient follow-up, we just, okay, he has vasculitis, how are you doing? Next. So we have to, every time we see them in clinic, we have to think again, go back. Is it really vasculitis or not? And of course, most importantly, and this is one of the reasons why I'm here, is that we have to be multidisciplinary, discuss with neurologist, discuss with rheumatologist, radiologist, neurosurgeon, infectious disease specialist, pathologist, all have to be in the same page. And I think in those cases, it's always good to take second opinion on everything, because sometimes you get enlightened by hearing other people's opinion. And by that, I conclude. Thank you very much.